Bernadette Lettner, who is a treatment nurse currently with the Toronto Community Hepatitis C program, who has more than 12 years of clinical experience and currently supporting treatment and care of persons living with hepatitis C who use drugs and alcohol, including persons who are homeless. You'll also hear from Doug Belanger, who's a community health worker with the Toronto Community Hep C program. He also has lived experience with hepatitis C and has a lot of experience in working with populations at risk for hepatitis C. So let me turn it over to Bernadette and to Doug. Welcome.
I think you'll just want to unmute you.
Great, thanks so much, Lindsay.
Thank you.
So yeah, if we can just jump right onto the second slide there. So the first thing I just want to touch base on is oftentimes we end up thinking of people experiencing houselessness or people who are homeless as not actually having a community of care associated with them. So I just want to challenge that. We've often heard of the saying, home is where the heart is, and I think that we have to look at people and folks experiencing houselessness as embedded in communities and embedded in communities of care, and how do we engage folks within that community. Next slide. So Doug's going to tell you a little bit about the Toronto Community Hep C program and the work that we do.
Toronto Community Hep C program has been around since 2006. We are connected with 4 other health centers here in Toronto. The ideal is to make up Hep C testing and care accessible to anyone. We believe that everyone can successfully cure their Hep C.
Jump on to the next slide. And a bit of an overview of how we do that work.
We have CSWs, who are people who have gone through the treatment with us, and they have gone on to complete peer training program and have been hired to work in this field. We also have a continuing care group, a way for people to stay connected and accessing supports one-on-one. We also have a patient advisory board, a group made up of people with lived experience of Hep C and treatment who advise and direct programming. Sometimes people choose not to be participant in groups, and sometimes, like with incarceration and geographic distance, they are unable to. So we will offer one-on-one support tailored to the individual.
We'll jump on to the next slide. So a couple of things ended up changing recently around how we offer services as a treatment group, and one of the first things I just want to touch base on was the COVID shuffle, as we like to call it. So there was dangerous overcrowding in shelters in downtown Toronto that led to high rates of COVID infection and some deaths. And so as a result of that, they ended up deciding to move people from downtown shelters into hotels that were vacant at the time. And that really had a result of displacing people from the community and connections that they had previously been able to access. So very early on, we decided that outreach to those hotels was something that was really important for us to do. So to be able to offer testing and treatment in hotels where people were being sheltered. Now, after kind of the waves of COVID happened, those hotels were closed, which led to people trying to re-access shelter systems downtown, but the capacity of shelter systems didn't increase in order to be able to allow people to come back into shelters. So what happened is people started moving into parks, and so now there are a lot more encampments in downtown Toronto, and as a result, as the summer comes up, encampment clearings have increased once again. So people's homes are being removed from the parks in which they set up. So what this has created is a much less stable geographic area for people experiencing homelessness to stay and base themselves out of. Next slide. Another big thing that's happened is this digital divide. So while I'm sure I certainly have had more medical appointments virtually over the last couple of years than ever before in my life, for people who have phones and computers, web digital access, that's great. For people who don't have them, then that means there's virtually no access. So what we ended up doing is providing devices, both phones and tablets, to individuals to help. We noticed that sometimes even providing devices wasn't enough, so we started to create touchdown spaces for people to connect on computers. And we've also developed this idea of doing online accompaniments. So instead of accompanying people to a location for their medical visits, we now do online accompaniment and work through tech challenges with individuals in that way. Also provide a space where people can end up answering and asking questions about those appointments. Next one. As John ended up alluding to, part of the reason that this work is so important is the equity piece that's part of this. So life expectancy for people experiencing houselessness in Toronto is significantly lower than the general population. We know that people have complex health needs, but they also have very high engagement in care. So we need to end up looking at how we respond to people experiencing houselessness as a population and not just use general guidelines to end up addressing the unique needs of people experiencing houselessness. So an example of this, when we were looking at rolling out COVID vaccinations in Ontario, it was by age demographic. So people 80 plus, and then 75 plus, and then 70 plus. Now, if we use that same rubric in order to look at vaccination for people experiencing homelessness, we'd never get to the place where people are being vaccinated if a life expectancy is 42 years instead of 85. So what we were able to do in conjunction with an infectious disease team at a local hospital was provide COVID vaccinations to people living in congregate settings. In the initial wave of vaccinations, we had really high uptake, 80 to 90% of folks were vaccinated, and that decreased outbreaks in congregate settings. So when we're talking about hepatitis C and hepatitis B, it often means that people experiencing houselessness have more advanced liver disease at a younger age. So screening and comprehensive healthcare are an important part of how we do equity-based healthcare and health interventions for priority populations. Next slide.
Engaging.
So how do we do this? Go ahead.
Engaging in community, using people with lived experience in all levels of our organization.
So from frontline workers to management, people with lived experience of injection drug use, of houselessness are employed throughout. And then when we're engaging in community,
we leverage the connections.
Yeah, we take a look at people who are community champions. So who do we know in the community who's a leader, and how can we end up using their connections to community to be able to engage in specific needs that that community expresses? We leverage connections. So everybody's connected, right? Oftentimes we end up getting referrals from folks who say, like, this person didn't show up, they were a no-show, and that's the end of it. We can't go any further with this referral. So oftentimes when we engage with people, we talk about consent early and often. If you don't show up next week, can I end up calling your local pharmacy? Can I talk to the person at the drop-in who's your worker? Can I give a call to your parents that you end up checking in with once a week? That kind of thing. So we support the relationships that already exist. If somebody does go to a local pharmacy, that's where we're going to end up doing their Hep C treatment, right? So making sure that we're building on the community connections that already exist.
Consistent, same time, same place for 17 years.
You know where to find us.
Yeah.
And part of this work is also very bidirectional. So we're constantly learning and evolving. We work on our communication on a regular basis with folks. And part of the reason that we're able to do this work is because Ontario ended up committing funding to hepatitis C treatment teams, and that funding has been consistent for the last 17 years. Next slide. So what are some of the approaches that we end up using?
Test and treat anywhere, and
yeah, so we treat people when they're ready. If somebody tells us we're ready, then we're going to end up working on being able to support them in treatment. So sometimes people have like ideas of what somebody needs in order to be able to engage in treatment in a successful way. I got to tell you, I've been proved wrong more times than I've been proved right. If I think that there's something in the way of somebody accessing treatment and they tell me they're ready, they're right. They're absolutely right.
Immediate contact, getting phone numbers, publicly available.
Yeah, so all of our phone numbers are available. So Doug has a work cell, I have a work cell, people know how to contact us, and we're constantly visible in the community.
Planful care, anticipate, communicate, and eliminate.
Yep. So often one of the questions we ask when people are first connecting with us is, do you have any outstanding warrants? not because I'm nosy, but if you end up being picked up and brought inside, I want to make sure that we're in touch with the corrections institution and we're able to end up transferring your medication with you. So we anticipate needs that people are going to run into. We communicate what those plans are, and we also end up working at connecting individual circle of care. So we're not just looking at one individual and treatment for that one individual. We're looking at how we can end up using that individual as a contact to a wider community. So part of how we do this, we did some pretty intensive postal code mapping at one point in time. We were looking at the referrals that we received for people who didn't actually make it down into our center. And what postal code were they at? How could we end up finding them? And then we would develop testing and treatment strategies in the community so that we could go directly to those locations and work in partnership with people in the community to chase prevalence and find people in the right place at the right time. Next slide. So some of the components of what this work looks like.
Is housing support.
So it's very needs-based, right? So if somebody comes to Doug and says, hey, I need a tent,
I will get it for them.
you'll find a tent. Part of the work that we do is looking at co-location, and partnerships are really key on this. So we go to places where people are accessing services. There's a community barbecue, we're sitting outside.
Yeah, and then we have referrals.
Constantly working on referrals both in and out, and those ongoing connections. So part of the way that we end up maintaining connections is through our continuing care groups, where people who following cure can end up accessing an ongoing support group. We do peer training, we do research engagement on a regular basis, and we have our participant advisory board. So next slide. Some of the thing that supports this work, I know that we're lucky in the context that we currently have. Our public health laboratories have done reflex testing for us. So if somebody is first-time antibody positive or they have no viral load on record, they will automatically reflex an antibody test to viral load. They've simplified what our testing is, so it's just a single serum tube that we end up needing. And we can also end up using dried blood spot testing for folks. With point of care testing, we use a 5-minute read rule. So if an antibody test is positive at 5 minutes, we go directly on to confirmatory testing. And we've been able to expand testing by training people with lived experience to provide hepatitis C testing in connection to care. All of this work couldn't happen without integration. So we're integrated within supervised consumption services, within harm reduction distribution services, within pharmacies that end up having high numbers of people who end up accessing services for methadone, Suboxone scripts, or opiate safer supply programming. Next slide. And then a little bit about the work that we're about to do. So we've got this idea that we can end up achieving Hep C elimination in Toronto, and in East Toronto is kind of like a little microcosm of our world. So the first project, next slide, that we're looking on is emergency department opt-out testing. So this is actually a slogan, and one of the members of our Hep C treatment team that came up with this. So we're looking at launching this in June. There is a hospital in East Toronto that connects with about 25% of the population on an annual basis, and of those, about 60% have blood work drawn when they're in the emergency departments. So what we're going to end up being able to offer is opt-out testing for everybody who ends up having blood work done already in the emergency department. And through a partnership with the hospital and the Toronto Community Hep C program, we'll ensure people are referred directly for treatment from there, because we know people experiencing homelessness and people who inject drugs are routinely not referred to hepatitis C care. We'll see hepatitis C on the problem list, but no follow-up referral to treatment. So risk-based testing is notoriously bad at identifying and appropriately stratifying risk, especially in an emergency department setting. Additionally, there's a vested interest in people avoiding stigma and discrimination in episodic care encounters, and so they don't disclose risks for hepatitis C. So one way to combat that stigma is to offer universal testing to everybody, ensuring people are identified and provided with high-quality responsive care in a single access pathway. Next.
Point of care testing, comprehensive training program for community organizations that want to operate CV antibody testing. Service users they are connected to, navigators with lived experience connecting to each of the sites and supporting testing and connection to care and offer treatment navigation.
So we were really lucky in being able to receive one-time funding to buy a whack of point-of-care antibody tests. And we decided that we would do like a training blitz. And so people who are interested in being able to create testing sites throughout East Toronto are going to be able to do that and link us directly to care. Next slide. And the last one we'll talk about quickly is called the one drop, one stop. So this is going to be a finger stick testing and immediate treatment start with RN-led treatment starts for folks in a supervised injection service. So finger stick for hepatitis C antibody viral load, also HIV and HBV, and then we'll be able to do a fibrosis assessment as well using an APRI. So we'll do liver enzymes and CBC on individuals. So what are some of the ways that end up allowing this work to be done? Next slide, two big things.
Community and consistency.
So making sure that there's an ongoing commitment to community building, being aware of what's happening in community and being able to change your services to respond to that, supporting people in what's impactful in their lives, and being consistent, being there for people, continual open doors.
Yeah, and always have the connection.
So we'll end there with thanks for letting us talk a little bit about how we do this work and what drives us.
Thank you.